The Confidence Doc podcast is brought to you by My Evergreen Med Spa. Located in Houston in the Woodlands, My Evergreen Med Spa brings to you the latest aesthetic treatments in the most luxurious environment. Remember, My Evergreen Med Spa, it's me time elevated. Welcome back to the Confidence Doc podcast. I'm Dr. Rednam. I'm a board-certified plastic surgeon in Houston, Texas, also known as the Confidence Doc. And today we have a guest all the way from Costa Rica, on his vacation, I might add. Welcome to the show, Dr. Manuel Chacón.
I'm honored to be part of this very known podcast, and I'm ready to answer all your questions.
So, Dr. Chacón, you are a pioneer right now in the breast world, and I have to share with everyone, I just came back from getting to work with him for a couple days, so I have lots to talk about. But what I really found interesting with spending time with you is you have an approach that I think is very different. So let's talk a little bit about how you approach women who are coming to you to talk about their aesthetic breasts.
So it's interesting because it has been in my background. I started to be a plastic surgeon, and I was focusing more on face surgery, and so I wasn't a fellow in the breast world. I was a fellow in the face world. So when I started to do breast, I didn't have all the bias that most of the surgeons had. So from the beginning, I started wondering first, what is the base of the breast? How much volume do we have? Like in most of the face procedures, it's like if you had a mole in your face, the first question that your attendee will tell you is what size of the wound you have. Then where do you have extra skin and how you would take it there. And in the same way with in breast, how much breast volume do you have? Where do you lack? How you take volume there? And so it has been my first 3D system. I got it in 2012, and we started to, at the beginning, more as a marketing tool, but we started to see volumes and projections. And then we were telling the patient, okay, I want a 300 cc implant, but you already have 300, 350 cc of breast. So the things didn't add up. So one of the bases of our consultation is try to remove all this breast implant-based talk, and most of women start talking about their breast implants like if they were cars or other things that they can take the same car than another person, and it would fit themselves. And this is one of the biggest mistakes we have. So, and the more I got into the breast world, we saw the same happen to surgeons. So if I go to a breast meeting, you ask all the surgeons what is the medium implant volume that they use. They all know exactly the implant volume. And you ask them, okay, what is the pre-existing breast volume of your patients? And they don't know, or most they don't know. And you ask them, the question is, what is the final volume of the result that you had? And they don't know. So the patient doesn't know it, the surgeon doesn't know it, even the manufacturers don't know this data. So imagine an equation that you don't know where you start, you know exactly what you put in, and then you don't know what your result is. So that's why we got in this world of I have this amount of volume of implant, regardless of the amount of volume that we have. So I think this is one of the biggest thing in breast aesthetics is to educate patients first. Then it works for surgeons will be a lot easier, because I know they're trying to do their best, but at the end it's very hard to a young surgeon or even a experienced surgeons to change the way patients think.
And you're right. When we're in training, we really are the only focus we're ever given is the base of the breast, and we use photos, we use other things, but it isn't scientifically based. And when we're doing that in other parts of the body, it doesn't make sense that we haven't evolved to do that in the breast as well. So you say you use imaging. Can you describe a little bit more in detail, like how you go through a consultation with a patient when you are talking about, and they come in and they want to have an augmentation?
So first, we try to uh, give them a baseline of how they are at that moment. So every time a patient comes to the consultation, we start by doing impedance measurements. So height, weight, percentage of fat, BMI, everything. We have a very high-tech technology. Then we do 2D pictures, full body pictures. So we try to include not only the breast, but the shoulders, the hips, and the whole body. And so they can see themselves. And then we do measurements of the torso, over on the shoulders, on the breast, under the breast, on the hips, in the waistline. And we do 3D imaging, and with the 3D imaging, we try to get the pre-existing breast volume, the projection that we already have, and then also the shape of the thorax. So when the patient comes in, we put everything in a big screen, and you have a big all the 3D information in one side, the full body picture in the other, and all the anthropometric measurement in a small in the lower part. And with this, we can approach the patient, and they come and say, I was thinking on having the result of this friend or this implant volume. And with this, let's start by knowing you.
And I will say, from both the patient side and the surgeon side, this gives both people a lot more gives them a lot more perspective on what's happening and a lot more education to understand what they can have from a realistic expectations. Because I think, for any plastic surgeons listening, we will tell patients, hey, this side is sits differently, or this side, but until a patient actually physically sees it themselves, it's very hard for them to understand what we are seeing. Right?
So yes, and first we have to remember that having a breast augmentation is a completely unnecessary procedure. So when we say that, we remove a lot of pressure from our side and from the patient side, because if they don't are pleased with our recommendation, or they don't have to do it. And then it's important also that volume, that the condition that the breast has can change. So I always tell the patient, you should know, if you want to have babies in the near future, maybe we should not have the procedure yet. What is the near future in the follow couple of years? Because these things can change after 2 years. Maybe they don't have the same partner. Then the other thing that with the impedance we can say, okay, your body fat is a little higher. Are you planning to lose some weight or get? Yes, doctor, I'm just in that process. So what is your goal? I want to lose 3 or 4% of fat, or lower 1-2 kilos of fat. And you know that you may lose that in your breast. I didn't know that. So maybe we should see each other in a couple, 2 or 3% of fat, or 3 or 4 kilos of fat, of kilos less. So that becomes very important. So they are aware that the changes that they're going to do will affect or benefit the result.
And
Then,
you'd measure. Oh, sorry. Go ahead.
no, please.
I was going to say, you'd mentioned you take measurements throughout their whole body, right? When we see a lot of people's before and afters or the results, they show from, here to here. They show up to maybe the belly button. But so can you explain why it is that you're measuring everything, why you're looking at their whole body?
So one of the big things that we have seen is that people don't know themselves. So the fact of first of all, we can see little asymmetries. We focus in the breast. Sometimes we see a little asymmetry in the fold, a little symmetry in the nipple, and we plastic surgeons, we want to have the perfect nipple and the perfect fold. And sometimes the asymmetry is in the shoulders. And so there's not any asymmetry, is that her left shoulders are lower than the right. So, and how frequent is this? We started look into this more into it in the last year and a half. In the beginning, we thought there were 2 out of 10 patients. Now it's 7 out of 10 patients that kind of asymmetries. So, and if we correct this asymmetry as surgeons, when they put their bathing suit, it's going to be lower in one side than the other because it was never a problem before. So this is important for us as surgeons to know. Then we try to see the proportions. And I say the first proportion is the relationship on the width of the thorax and the width of the hips. So if we have a woman that have large hips, Latin women have large hips. So if they want to look as thinner as possible, we have to keep as thinner possible the thoracic width. And why is important? Because since the thoracic shape is like this, the heavier is the breast, the more it will trend to go laterally, and then we're going to have a sensation to be heavier or to be. So this become important, and we see the opposite when we do a breast reduction. They look heavier, and only by doing reducing the width of the thorax, they look slimmer, they look thinner. Then the second proportion is the height of the aesthetic thorax. So I always tell them, okay, what is your aesthetic thorax ends? In the inframammary fold. Where is your upper border of your aesthetic abdomen? Is the inframammary fold. So the position of that breast in the whole torso becomes very important. So if we have a long, high positioned breast, that means we're going to have a long abdomen. So the woman looks a lot thinner and slimmer. And every woman wants to look like this. So every time, with different techniques, the patient wants to have a little more volume, we need to lower the inframammary fold. And by lowering the inframammary fold, we shorten the abdomen, and then the proportions going to be changed by us. So I always tell them that I used to do that, and I have patients that had come back to me, and I had lowered the fold and say, the problem that you have, you don't know, and I didn't know, but it was caused by me. So, and now, when I have this picture, we have the same woman with the same breast, but different position in the torso of the breast, high-breasted, mid-breasted, and low-breasted. And when they see that, they see that I don't want to have a shorter abdomen. And a lot of the implant decision is based on that decision on the symmetry and the proportion of the body.
And I think that, why I enjoy getting to see your process so much is that I think that later down the road, we run into patients who will come in and say, I don't like something about it, and they can't quite put it in words. But this is really taking that process at the beginning and explaining it so that you don't end up doing a surgery and then find that somebody's not happy about something that we could have prevented by educating better on the front end. And so I think that that's very important for us as plastic surgeons, is that we're the ones that know these things. And so we have to make sure that we're doing the best job we can educating our patients so that we give them good long-term results, not just in the immediate.
Yes, and also sometimes we have a little harder cases. And so the more the patient is involved in the complication that they have, or the decision that they want to make, the more they are aware of the more they want to prevent those complications. Mm-hmm. Mm-hmm. So I tell always, we have fellows as well. They don't suffer alone. Include the patient in the process, because like that, they don't want to have any problems. They don't want to have any complications. They believe that they want something, but maybe that something is not the best for them.
Yeah. And we all want our patients to be happy. We all want them to achieve what they want, but at the same time, they should know the risks as well as the benefits. And a lot of times it's so heavy on, I want to look a certain way, that they haven't given thought about what all these potential risks are down the road.
And the other thing is that you maybe a line that is being used a lot. We want the best version of themselves. So it sounds too cliche, but it's true. We want her to be their best and have the less complication possible. And also, we include something that very few people talk about. It is, when do we need a larger breast? So so most of the time, if we and I always ask the patient. So if she's a professional and a mother, or so you don't need to exercise a larger breast. You don't need that to go to work a larger breast. You don't need for sleeping. Only for very few moments in life in the year, like when you use a bathing suit, when you use a cleavage. So most of the time, the result has to be comfortable, has to be easy to dress, easy to sleep, exercise friendly, and that you almost forget that you had a procedure. Because most of the women who had a breast augmentation, they don't have that much breast volume, so they don't have the problems of the woman who had a large breast. So they should be aware of what that little extra that they want, what is the consequence they may have. So they should be able to sleep comfortably, exercise comfortably, use any kind of clothing, and also be able to look as well at the best they can for
Mm-hmm.
the longest time possible.
Well, and one of the things that we've been limited by in the US, especially, right, is that if you do want certain areas of your breast to have volume, you have to put an implant that's going to have volume everywhere, because that's what we have. But one of the things that you are probably the world expert in right now is figuring out ways to do that differently. Are you able to explain to us what I mean when I'm saying that you know how to be able to place volume where it's needed in a breast and not necessarily everywhere?
So then, big part of understanding the breast volume is understanding breast tissue distribution. So if we know how much volume do we have, okay, where do we lack? And important to include that in the patient evaluation, and they see, and we have created what we call breast topography. So it's like the topography of a mountain, but in the breast. So you can see the lines and really explain the patient where they lack volume. So they can really understand if they were putting an extra volume will be, and this is typical upper and medial. That's the typical area that we normally lack that volume. So now that we have new technologies, especially developed by establishment labs, and this technology was first started by the MIA procedure, and now the Preserve procedure, and we have learned that we can position the device wherever we need it with these new technologies that we have. And I think this will be a game changer, because most women have volume. I know in America there you have a big mix of different type of women, but more like in my consultation, the median pre-existing volume is 250 cc's. So and we don't need that much to add. So with these new technologies, we can really position the device where we want, and the device stays there. So we don't need to put that much volume.
And I think the key is, like you said, understanding the topography of the breast and understanding the importance of preserving what the natural anatomy is of the breast.
Yes, and one other thing that is a big change is the fact of going from behind the muscle to in front of the muscle. And this is something that I always tell the patient when they come. You know, and you have heard that it's better to position the implant behind the muscle. Yes, doctor, I have heard that. I have Googled that, and but yes, you know that this technique was developed 25, 30 years ago in a group of women who didn't exercise. So it was your mother at your age. And if you ask your mother at your age if they exercise, they say, no, I didn't have time. Or if they exercise, there were very few women who did. So are we going to use a technique that was developed 25, 30 years ago in you, or we adapt the technique to you? So to adapt the technique to you, we have to preserve the muscle, because most of the women, I know in the US it is, in Costa Rica it is as well, they exercise. So we can have motion deformities on other things that they don't want to have, and it's very hard to prevent, or even only by the fat recovery that they will give them. So that's a big shift of going from in front, back to behind the muscle to in front of the muscle. Then we go to the next thing, that is, can we, because a lot of surgeons have said we have positioned the implant in front of the muscle for a long time, but with these new technologies, we'll be able to really put the implant just with the breast. And this becomes so important because the breast moves normally behind, with the space they have behind. And it's held by the ligament that are all around. So that normal movement of the breast, we can also preserve that movement and put the implant just in the posterior part of the breast as being part of the breast.
And what do you say to the people who get concerned? Okay, if we're going above the muscle, what about rippling? What about the how the implant will look?
So part of the change, okay, we're going to change the rules by going in front of the muscle. We're going to change the rule by preserving the ligaments, but we need to change the technology of the device. And that's why this new technology, sixth generation implant, is so important. And we start by the surface of the implant. So this 4 micron surface is so biocompatible that almost doesn't create a capsule. So by lowering this small tissue that is around the implant, we have less possibility of that rippling, of that sensation. Then the technology on the shell of the implant, since you have a shell that is thinner, then you can transmit the softness of the gel with to the tissue without filling the shell and without filling the capsule. So that's the big game changer with this new technology. And then you have the softer gel. So with all this, you can go in front without any problem. And something that is very important, the world in breast reconstruction has gone in front of the muscle. And they don't have any breast tissue. So imagine all this recon area going in front of the muscle, preserving the muscle, and have less amount of coverage. So why don't we?
And I think that in plastics, right, reconstruction and cosmetic, though we like people will divide them, they're the same. So I mean, we can be better reconstructive surgeons, or better cosmetic surgeons by understanding from the reconstructive side, and it works vice versa. So I agree with you that if we've already moved there, why are we not doing this here when we actually do have tissue, breast tissue in front? It just doesn't make sense to do an old technique when we have newer ways to do things that are providing really nice results as well.
And this is all possible because of the changes in the technology of the new manufacturing. So without this, we will not be able to do it.
And we had a previous episode where we actually had a family member of yours on, and we talked a lot about that new technology. And so, those of you who may not know, is Dr. Chacón and JJ Chacón are brothers.
Yes. And my father is a plastic surgeon, and my mother is a nurse that worked for my father. So we
So,
learned the hard way.
yeah, but it's in the family business. But everybody is dedicated to providing better treatment for women, which is, I think, at the base of Estelle Labs, obviously.
Yes, there's my brother always say my father show me everything that was in the market, and my mother showed me everything that it was lacking. So that woman and male relationship, surgeon and nurse, and my mother was always, you like this, and my brother got it from the beginning, and I had the opportunity to be able to be one of the first to use it and to be part of this journey of learning from them, from the engineers, the new technology, and also from all the surgeons that had visited Costa Rica.
And I could tell you for our listeners who are potential patients, other plastic surgeons, that, when I first learned more about these new devices, I was skeptical. Like, I think we all always have a little skeptical. But really, I think this is going to change the way that we approach things. I think we're going to be able to provide more predictable results and provide our patients better long-term results so they can make better decisions. So I'm very excited for what's new coming in the pipeline to the U.S. as well. And I already have people lined up when that time comes. So, Dr. Chacón, thank you so much for being on the show and for sharing some of your insights with us. If somebody would like to learn more about this, what's the best way for them to follow you, for them to reach you?
I will. I'm going to share you my social media, and they can reach me through there. And for me, it's a real honor to be part of your podcast. It was an honor to receive you, and really thank you for inviting me and help me to share this new technology and this new breast era.
Well, thank you, and thank you for being dedicated to educating. I can tell you, when I got to visit Dr. Chacón, the number of surgeons on that wall. He's been so open and sharing everything that he knows, and that's a gift in our specialty. When you know something that can provide better care, to share it with people, so that we all can. So thank you so much. Enjoy the rest of your vacation as well.
Thank
And
you.
thank you. And thank you all. We will share Dr. Chacón's information. So if you want to learn more, follow him on social media. And thank you all so much for joining us on this podcast. And as always, I hope you learned something new.